Welcome to week 16, coders. You made it to the final week of this 16-week course. And you know what, coders? We are all very proud of you. It took a lot for you to get to the finish line, and you're here. Now, remember, this course will be available for as long as we have this channel. Now, of course, some of the lectures are going to get older, and we will do our thing. We'll keep our eye on it, and we'll try and keep the information as updated as possible. Now, coders, we might just have to have another one. Just saying. All right, coders, this week we're going to be diving into one of the most important and powerful sections of CPT coding, and that's evaluation and management coding. So get ready. A lot of people say, "Oh, I don't like it," or they're fearful of it, and the only reason is the guidelines. There are a ton of guidelines, but they are very, very doable. You can do this, coder. You have demonstrated your ability throughout, and I know you can. All right. So, before we go any further, let's go ahead and say hello to the team. All right. I'm going to call everyone by name, even myself. I'm Mrs. J. I never say it. Well, I haven't been saying it, so I'm saying it. I'm Mrs. J, Ms. Dolly, Ms. Mills, Miss Bianca, Miss Jayla, Mr. Sandeep, Miss Danica, Miss Yadira, Miss Tanisha. Hello, hello, hello. This is the AMCI team. And let's not forget our amazing interns who also show up week after week, encouraging each and every one of you. All right, please say hello to the team. All right, they're in the chat and they're going to, we're going to be here the duration, and we're going to end this with a bang. All right, coders, this is it. No more live classes on Monday. I am going to miss you. And I've told you, I promised you that at the end of the course, I will provide you with a list of free YouTube resources for you to exam prep. So, next Monday, and the reason we're not doing it today because you have homework that you need to focus on. So next Monday on July 7th, I will upload our recommendations for how to exam prep for the CCS-P, CPC, and CCS at no cost. Also, you will have access to the link on your syllabus on how to exam prep, okay? All right. Now I've got a special announcement. If this free course wasn't enough, now it should have been enough. It should be enough for you to kind of go on your own. It's almost like training wheels. So now we're taking the training wheels off, and we've taught you a lot of things for you to manage your self study. However, some of you might say, "No, I need more, but I can't afford that high priced course." Well, we've done something. Yeah. And you all inspired this. We've created several full, low cost instructional courses for you to independently prepare for the medical coding exams. Not only have we created these full courses, we've created smaller courses too, so that you can tailor your own instruction according to your needs. Now, these courses are high quality and will prepare you for the certification exams from beginning to end. That's if you take the full course. We have a CCS-P independent instructional course with exam prep and boot camp. We have a CPC independent instructional course with exam prep and boot camp. We have a CCS independent course with exam prep and boot camp. In fact, we have um, I would say a collection of courses, and you'll need to we'll furnish you with the link, but this link is on your syllabus at the end of the syllabus. So if you need anything, just search for it. So this is the page that you will come to, and it says, look at these links here. These are our collection of courses. So if you need a full course, then it would more than likely be in the collection. For instance, if you want to take the full CCS-P course, you click here. You want the instruction, exam prep, and boot camp. Click there. And then the collection will come up. It's going to say you'll need to take parts 1, 2, 3, and 4. However, coders, you are the captain of your ship. You don't have to take these courses. No, let's say you just want to review part 3, Advanced CPT. Let's say you want to review part 2. I don't recommend part 1 for any of you. If you've completed this course, I don't recommend part 1 at all. So, as you can see, they're $59.99 a month. So if you need 4 weeks, that is a good price. If you only need exam prep, you only need that part 4 for CCSP. So these are for people that need a full course. It's affordable, and we did it for you all. Now, if you, and I told you I was going to tell you about free resources. Of course, this is not free. So the exam prep for the CCSP is in red, it's $59.99, and the purple is for the CPC, it's $59.99. And there is an exam prep for the CCS. Here it is. This is the CCS. As you can see, there's one price for it. It's a flat rate for 6 months. That is, this is a comprehensive course. All right, so you can cancel at any time. It's very easy to do. And remember, this is an independent course, very independent. So you don't have access to the AMCI instructors, right? You can't, go to our student success team and say, hey, I need help with this, this, and this. Unless there's something wrong, right? We're ready to correct whatever we need to correct. However, if you have Discord, you can ask away. So, again, coders, you do not need to take these courses. You do not. They are here if you need them. All right? So if you click on the course, any of these courses, you can see the entire outline. All right. And the link is on your syllabus. So don't worry about this until you've finished everything and then make informed decisions. Speaking of Discord, Discord has wonderful instructional opportunities. In the IMTAP class, this is interactive medical terminology and anatomy and physiology. Oh, by the way, there is a free IMTAP course, Introduction to Medical Terminology and AMP course in our on our website, so you don't have to pay for it. If that's all you want, that's all you need, go get it. It is free. All right. So the link, I'll talk about it at the end. All right. Also, the game night. That is excellent practice. Excellent. So definitely, participate. That's 7 p.m. on Friday, and I'm Tap is 7 p.m. on Wednesday. And here's a little gem. Lunch with Mrs. J. I know maybe I'm biased, but all of these are great. But I do instruction there, and I clarify complex coding rules. I do. And I answer your questions. So if you are a silver or gold or platinum member, then you can, come sit with me on Wednesdays. If you can't make it, just submit your question. There's a place for you to send me a question. You can talk to me directly. Okay, Discord is very, very important. You're going to get your questions answered, and you can have all kinds of interaction with instructors, not just me. The other instructors are coming down the pike really, really soon. All right, let me get rid of this. If you want to join Discord, this is how you do it from your syllabus. These are the instructions. Number one, become a YouTube member. Click that link. After you become a member, you'll need to join Discord, the AMCI server. Click here. After you get into the server, you're going to see your image, and to the right, this is the settings cogwheel. Click on it. You're going to need to connect your YouTube channel with Discord. So when you register for Discord, make sure you use the same email address so that you can connect. So it should be easier. All right. After you click on this cogwheel, connections will come up. Then you'll have to find YouTube. Find the YouTube icon. After you do that, follow the prompts, and you should be in. If you still need assistance, contact AMCI, contact at amcicoding.com. And don't forget to tell everyone about this course. Yes, it will continue. We will still have the website up, direct people to the website so that they can get the syllabus. And that's all. And I want to thank you in advance. Thank you for telling everyone the web. Our numbers have increased and we can see that people are enjoying it. And anytime you have a suggestion, let us know. We may just implement it. And we are implementing some of your suggestions in Discord. All right. So thank you, thank you, thank you. Now let's get into our instruction. Right. CPT is copyright of 2025 AMA. All rights are reserved. Keyword concept FTR Chun, AMCI Fab 7, AMCI ICD 10 CM Philip Tap, and MCG are registered trademarks of AMCI. CPC, CRC, COC, CPMA, CPB, CPPM, CPCO, and more are owned by AAPC. CCA, CCS, CCS-P, RHIA, RHIT are owned by AHEMA, and AMCI does not own the rights to these credentials. Goals of the presentation for week 16. Number one, we will review evaluation and management, or we call it E&M. We're going to practice exercises to test your knowledge, and I may drop a gem or two, and hopefully will bring you one step closer to CPT coding mastery. Now, we do have a disclaimer. There is no possible way that we can get all of the content needed to teach you evaluation and management. So you will need to do the following. You have to go to your MCG manual, click on the link for the videos, and watch Evaluation and Management Parts 1, 2, 3, and 4. I'm going to need you to do that. And you can do it after this session. Although these are introduction to evaluation and management, I guarantee you it's going to make so much more sense after you've watched parts 1 through 4. All right? Also, don't forget in that MCG manual, that's where we've broken down all of the guidelines, and this is a quick look. And very quickly, this is how you select, or this is how you document your keywords, your inventory right here. Now, let's go ahead and define what is evaluation and management. What is it? Go ahead, type in the chat. Let me know, do you know what evaluation and management is? Well, they are doctor visits. It's when the doctor visits the patient. It could be in the ED, in the office, inpatient, at home, or the patient visits the doctor in the office. Nonetheless, these are doctor visits where doctors render face to face and sometimes virtual and sometimes not services, but services on behalf of the patient. In this session, we will instruct you on how to code E&M visits, and the code selection will be based upon the provider's documentation. Just like surgical procedures, we code from the operative report or the provider's documentation. E&M visits are coded based upon the provider's documentation. And it's done one of two ways. Number one, it'll be based upon the time that the doctor or provider documents or the medical decision making documented by that provider. Now, before we get too far into it, let's go ahead and get acquainted with Evaluation and Management Table of Contents. This is how the table of contents is outlined. All right, this top section here represents the guidelines. There are a ton of guidelines for evaluation and management, but we have clarified them for you, so no worries. Now, down below where this black bold begins, this is how the section is laid out. And they're laid out according to the doctor visits. So, office or other outpatient services, these are office or outpatient doctor visits. Telemedicine service, telemedicine visits. Hospital observation services, hospital inpatient and observation care services, these are visits. Consultations, emergency department, critical care services. These are doctor visits. Nursing facility services, domiciliary rest home, example, boarding home or custodial care services, domiciliary rest home, assisted living facility or home care plan, oversight services, home or resident services, prolonged services, case management services, care plan oversight services, preventive medicine services, non face to face services, special evaluation and management services, newborn care, delivery and birthing room attendance, and resuscitation services, inpatient neonatal, intensive care services, and pediatric and neonatal critical care services, cognitive assessment care plans, care management services, psychiatric collaborative care management services, transitional care management services, advanced care planning, general behavioral health integration care management, other evaluation and management services. Coders, the section that I've just read underneath the black bold, these are all visits. So when I say location, I'm talking about one of these green visit headings. All right. Speaking of green, let me get rid of this and we're going to move over to the green pages. And when you see these green pages, you'll know that these are general coding guidelines. In fact, these general coding guidelines are applicable to the following visits: office or other outpatient services, telemedicine services, hospital inpatient and observation care services, consultations, ED department, nursing facility, home or residence services, prolonged services, with or without direct patient contact on the date of the E&M service. So these guidelines are applicable to these visits. All right. Also, you have guidelines here on new and established patients, initial and subsequent services, split or shared visits. Let me turn. Also, multiple E&M services on the same day, what you can code and what you cannot, services that are reported separately, history and or examinations, also levels of E&M service. You're going to hear us speak about that today. The guidelines on selecting the level of service based on medical decision making, we will review that today. The number and complexity of problems, and this is the chart, the PDR chart. You're going to see our PDR chart today. Amount and complexity of the data to be reviewed. Also, the risk of complications and or morbidity or mortality of a patient management. Also, guidelines for selecting the level of service based on time. Okay, coders, these are the guidelines here. Also, unlisted services and what to do in special reports. So, at a glance, these are some guidelines and they are applicable to the visits that I pointed out. And just so you know, we do address these visits very quickly. New patient, established patient, physician covering, emergency room, initial and subsequent visits, split or shared visits, and more. We cover all of the topics and we've clarified the guidelines for each. All right. So when you get to the codes section, it looks like this. And this is pretty much how we recommend that you chun. It's different, right? Yeah, so you don't really have families. No, you don't have families in E&M. Not too many. You may see small families, but you don't see very many. But in this new patient section, so we're in the office or other outpatient services and new patient. And it's going to be your responsibility. Well, we recommend that you, at minimum, document the time of the visit and the level of the medical decision making or MDM. So this new patient is straightforward MDM and the time is 15 minutes. 15 minutes must be met or exceeded. So you just need to be 15 minutes here. The next code, this is low MDM, and the time documented is 30 minutes. That must be met or exceeded. When you get to 99204, this is moderate MDM with 45 minutes must being met or exceeded, and 99205, this is high MDM with 60 minutes being must be met or exceeded. And then when you go get up to 75 minutes, that's your prolonged visit. And you're going to have to go to 99417. So this is how we recommend, at minimum, chunning the new patient section. Established is done the same way. And also you'll see our applicable general coding guidelines at the bottom of the page. Now, let's go ahead and begin our instruction on selecting E&M codes or doctor visits based upon the documentation. And remember we said the code selection will be based upon the time or the medical decision making that the provider has documented. Now, let's go ahead and review what to abstract from that provider's documentation to select the correct evaluation and management code. And this is what you'll need to inventory from the provider's documentation. In general, you'll have to answer, was a history and or exam carried out? Number two, what is the location of the visit? Remember, I was pointing out in the table of contents, this is a location, this is a location, this is a visit. That's what I mean. Where in the book was the visit? Number three, type of visit. Is this new or established or initial or subsequent? Number four, what was the total time of the visit? If the total time is not documented, then you will need to score the medical decision making. Coders, for this exam, time will take precedence. If it's documented, obviously they want you to code it. All right, but in the real world, the MDM or time could play out. And you know what? Anybody, almost anybody can kind of, you'll see, will be able to kind of take the time from the documentation and code it out. However, a seasoned coder can look at the documentation, score it, and advise the provider that this level of service may indeed be higher. Just saying. All right, number six, you'll need to use the evaluation and management tables or the PDR tables to select the code if you need to score it. And finally, make sure that you apply all guidelines. So this is what you'll need to abstract from the documentation. We will show you, but let's begin with time. You don't need all of this. So let me explain what you need to abstract from the documentation for when a doctor indicates the time in his documentation. All right, so this is how you do it. You're going to answer the following questions. Where was the visit? What type of visit? What is the total time of the visit? Apply all guidelines. Now, speaking of guidelines, here are the guidelines for time and applying or using time to select the code. And they were right in the general coding guidelines section. As you can see, they are green. So this qualifies the provider to use time. So the physician or other qualified healthcare professional includes the following activities when performed. So they have to be doing one or more of these events to use or for us to code their time documentation. Number one, they have to be preparing to see the patient. They can be reviewing tests. Number two, obtaining and or reviewing separately obtained history, performing a medically appropriate exam and or evaluation, counseling and educating the patient or family or caregiver, ordering medications, tests, or procedures, referring and communicating with other healthcare professionals, documenting clinical information in the electronic or other health record, independently interpreting results not separately reported, and communicating results to the patient or family caregiver, and care coordination, not separately reporting. So, this is what they should be doing, one or more, in order to use time as a way to select the E&M code. All right, coders, now let's go ahead and let's solve our first scenario. This is our first question, and please note this is not multiple choice. This is probably best when we're learning. We're in the learning phase. All right. A 48-year-old male with poorly controlled hypertension and new onset headaches presents to his PCP's office. The physician spends 45 minutes total reviewing the patient's chart, examining the patient, ordering diagnostic studies, and counseling the patient on lifestyle changes and medication adherence. Okay, coders, your time probably has already begun, and we're not giving too much time because we have a lot of content. So go ahead and answer the question. And I want to apologize again for the limited time. Okay, coders. Mr. Sandeep will give you more time, but I want to get this instruction in. Okay, so the inventory based upon how to solve a scenario is we're going to document the location. We're also going to document the type of visit. This is an established patient as well as the time. We know it's an office visit because it says he presents to his PCP's office and the physician spent 45 minutes. And if it's their PCP, it is presumed that they have established a relationship. If they don't document, anything beyond that, it is safe to say this is an established visit and 45 minutes. Now, in order for us to code out the time, they have to meet one or more of these elements that we've mentioned, right? So these are the guidelines for time, and it does. It meets all three of these within this box. Performing a medically appropriate examination and or evaluation, counseling and educating the patient, family and or caregiver, and ordering tests or procedures. So that did happen. The doctor did carry out these items. He spent 45 minutes examining the patient, ordering diagnostic tests, and counseling the patient. All right, so we can go ahead and use time. So I'm going to use the time. There are little charts in the front of the E&M section. I'm going to use those little charts. All right, here they are. So we know that we have an office visit for an established patient, and the doctor spent 45 minutes. So we're going to have to find the established office visit chart. Well, this is new. Here is the established visit, established office or other outpatient service. I found it. Now all I have to do is look at the bottom and determine where my time falls. And if I'm looking correctly, it falls in the last column. This is 40 minutes and it falls under 99215. All right. Now I'm going to go verify because I'm not sure. I have a 45-minute encounter. So I'm going to go to the codes and I'm going to look it up. And here you go. If you go to 99215, this is the code for office or other outpatient visit. When using total time on the date of the encounter for code selection, this encounter must be 40 minutes or exceeded. So 40 minutes must be met or exceeded. And that is our case. Now you might say, well, what do we do if it's 60 minutes? Well, if it's 60 minutes, coders, below there's a parenthetical guideline that says for services 55 minutes or longer, used prolonged services code 99417. Okay, coders, how'd you do? If you said 99215, outstanding. Way to go, way to go, way to go. All right, we have another question. A 34-year-old female presents as a new clinic patient for evaluation of anxiety and insomnia. The provider spends 30 minutes total reviewing her medical history, assessing symptoms, discussing treatment options, and counseling her on sleep hygiene and medication. No significant physical exam was documented. Go ahead, select the E&M code for this visit. Okay, coders, you can do this. How are you coming along with those keywords? It's pretty straightforward, but it does take a little time to get the hang of it. But when you do, you do. So keep going, coders. All right, so my inventory for this time based encounter is the location is office. The patient was seen in the clinic. This is a new patient as per the documentation. And finally, 30 minutes was spent reviewing her medical history, assessing her symptom and treatment options, and counseling her on sleep hygiene and medication. Yeah, so we can go ahead and select the code based on time because it meets one or more of these documentation guidelines. All right, let's go ahead and solve our scenario. So I do want to use these charts again, and I want you to get in the habit of trusting them because they are accurate, right? So we have the location is office and new. So I'm going to go up to the new office chart and I'm going to look for 30 minutes. And boom, it's here. And if you go up, this is 99203. Now, as always, we need to verify that. Before we code it out, let's go ahead and verify. We're going to the code 99203. This is low MDM, and the time is 30 minutes. 30 minutes must be met or exceeded, and that is our case. So if you said 99203, outstanding. But if you learned something, coders, that is priceless. All right, let's move on to the next scenario. A 65-year-old male admitted for pneumonia is seen on day 3 of his hospitalization. The physician spends 27 minutes on the unit reviewing labs, evaluating response to antibiotics, coordinating care with nursing, and counseling the patient on oxygen use, then discharged the patient. Okay, coders, select the E&M code for this visit. All right, coders, your time has already begun. Go ahead and put your answers in the chat. Okay, here is my inventory. We have a hospital discharge. This is the location in the facility. This is the location that I'm going to code from. Also, this is a subsequent visit, and the time is 27 minutes. Now, how do we know if we can use time? Does it meet the criteria? Did the patient prepare for did the doctor prepare for the patient? Absolutely. The doctor reviewed the patient history, the labs, and response to antibiotics. The doctor did counsel the patient, yes, on oxygen use. And finally, care coordination with the nursing staff. So, yeah, at least one or more of these elements were met, and we can use time. However, somebody might have the question. They might say, how do we know when to use a subsequent hospital visit versus a discharge visit code? That is a great question. And I say to you, always ask yourself, what is the objective of the visit? So let's ask that question. Let's answer it. Ask and answer. What's the objective of this visit? Was the doctor's objective to visit the patient and say, "Hey, how you doing?" Just check on the patient? Or was the doctor's objective to discharge the patient? Of course, it was to discharge the patient, right? Absolutely so. That's going to be a gem. The gem is when you don't know what to code, ask yourself, what is the objective of the visit? And also read, 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 read. I'm going to show you why. And if you go to the guidelines are right at the discharge management services. The formal title is Hospital Inpatient or Observation Discharge Services. If you go underneath and read it, it says basically if you are the discharging physician, you will use the codes within this section, and there are only two: 99238, 99239, and you are to use the total time spent discharging that patient or providing discharge management services for that patient. However, if another doctor sees the patient on that day, they use 99231, 99232, and 99233. And also, I want to point out that a doctor can spend more than one day managing a patient's discharge. So that time is total time. All right, so hopefully that makes sense. Now let's go ahead and let's code our encounter. All right, so we know that this is hospital discharge and 27 minutes was spent with this patient and discharging this patient. All right, so if that's the case, if you look at 99238, this is the code for hospital inpatient or observation discharge day management. 30 minutes or less on the day of the encounter. So 30 minutes or less was spent, and this is our code indeed. So if you said 99238, outstanding. Yeah, I know that was a little difficult, but I think you get it. And if you don't have it quite yet, you will. Read those FTRs and do practice exams, and you'll get it in no time. All right, it's time to move on, coders, and we're going to talk about medical decision making. All right, let's do it. So, again, the doctor visit will be determined based on time or the medical decision making. And pretty much, it's all summed up this way: we will have to score the documentation. Yes, we are going to score the number and complexity of the presented problems. We are going to score the amount and the complexity of the data reviewed. And finally, we will score the overall risk of the patient. And this is what we call at AMCI PDR. P for the problems, D for the data, and R for the risk. And this is the PDR chart. This is the original PDR chart. We've changed it for 2025. I'm going to show you that chart. In fact, we're going to be using the 2025 chart, but essentially, the chart is outlined in the following way. The first column represents the problems, the second, the data, the third, the risk, and then your result is here, and the code is in the fourth column. So, It's up to you, coders, to make sure that you understand these definitions. If a patient has a self limited or minor problem, this is going to be a straightforward problem. However, we get into the low section. If a patient has two or more self limited or minor problems, or one stable chronic illness, or one acute uncomplicated illness or injury, or one stable acute illness, or one acute uncomplicated illness or injury requiring hospital, inpatient, or observation level of care. Any of those qualifies for a low problem, a low P. Moderate is when you have one or more chronic illnesses with exacerbation, progression, or side effects of treatment, or two or more stable chronic conditions, or one undiagnosed new problem with uncertain prognosis, or one acute illness with systemic symptoms, or one acute complicated injury. It's a moderate problem. And finally, we have a high problem. And when the patient has one or more chronic illnesses with exacerbation, progression, or side effects of treatment, or one acute or chronic illness or injury that poses a threat to the life of the bodily function. So that is a high level of problem. Now, the data is straightforward when the patient has minimal or no data. The data is low and they must satisfy one of these categories. We have category 1 or category 2. In category 1, you have to have two elements. You have to review of prior external notes from each unique source. So every source is one element, all right? Ordering of each unique test. So you can check off, give it a check for every test, and that will satisfy two of the element requirement. Review of the results of each unique test. Same thing. Or it's a category 2, assessment requiring an independent historian. All right, coders. So it's low level, level 3, if any of these elements are met. Now we get to level 4, moderate. Category 1 says that they have to have any three from category 1. Any three of these have to be checked off. Not three of these each, but it could be one with three checks. So three, right here, ordering of each unique test, you can have three tests. So hopefully that makes sense. So review of prior external notes from each unique source, ordering of each unique test, or review of the results of each unique test or assessment requiring independent historians. Category 2. So you got to have um, independent interpretation of tests performed by another MD or provider, appropriate source, not separately reported, or category 3. And category 3 is discussion of management or test interpretation with external doctors, appropriate source, not separately reported. And then it's high level when you do the following. You have to have two of the categories. You have to meet two. So category 1, review it's pretty much um, the same as 4. The category 1 is the same as 4, and category 2 is the same as 4. Category 3 is the same as 4, but instead you have to meet two of the categories. And risk, coders, I'm going to just tell you, risk is subjective, right? The risk of complication, morbidity, and mortality, it's straightforward if the treatment was minimal. It's low if the treatment was low or the risk is low. So you're going to have to figure that out, coders. You are. So you got to use your discretion, and we will do it together. Also, It's moderate. And here are some examples of moderate. And a common one is prescription drug management. When a physician writes a prescription, it's automatically moderate risk. The decision made regarding minor surgery with identified patient or procedural risk factors, it's moderate. Discussion regarding elective major surgery without identified patient or procedure risk factors, and diagnosis or treatment significantly limited by social determinants of health. These are all moderate risks. Now, when you get to high risk, here are some examples. Drug therapy requiring intensive monitoring for toxicity, decision regarding elective major surgery with identified patient or procedural risk factors, decision regarding emergency major surgery, decision regarding hospitalization or escalation of hospital level of care, and finally, decision not to resuscitate DNR or to de escalate due to poor prognosis. All right, coders. So these are your problems, these are your data, and these are your risk. And these can be found in the front of the E&M section in the green page guidelines. It defines all of these. So if you need clarification, that's where you go. So after you've checked off your PDR, you look at your level and then you select your final code. Now, level is a technique that I'm going to show you, but you can do it. And two coders, this should not be foreign. If you've studied path and lab consultations kind of are determined the same way. Their chart looks very similar, so it is similar, and a lot of the definitions are similar. So, coders, we can do this together. Now, let's take a look at the 2025 PDR chart. And here you go. It's a little more compact, but just so you know, you have straightforward, low, and moderate here, and then high is on a page all by itself. I apologize, we couldn't get it on one, but I think it's more important that we see the content versus it being aesthetically good. All right. So here, I like this 2025 because you can, I would just, you got a little check mark box here. So check as many that apply, right? Put check marks in that box. Put as many that apply. All right. So you've got your straightforward going across here, your low, your moderate, and high. And you see the P, problems, the D for data, and the R for your risk. Now, there's no leveling, but there is your code and leveling together. Your level and your code are together. All right, I'm just going to get into it. Yeah, let's do it. And before we solve any scenario, let's go ahead and review how to abstract or inventory from the provider's documentation for medical decision making. Number one, we're going to have to extract whether or not a history or exam took place. Yes, you must have a history and or an exam. Number two, the location of the visit. Number three, the type of visit. Was it new, established, or initial or subsequent? Number four, medical decision making. If you have to, sometimes doctors flat out say this is low MDM. If the doctor specifies that it's low or specifies it in the documentation, that's it. In the real world, you can still score it. You might come out differently, and often that could happen. But for this exam, if the doctor specifies the MDM, just go ahead and code it. However, if they don't, you'll need to use the E&M tables or that PDR chart. And finally, apply all guidelines. Now, let's go ahead and let's begin our first MDM scenario. So we have a multiple choice. What is the level of the MDM for this visit? A, straightforward. B, low. C, moderate. Or D, high. A 36-year-old female with new onset migraine is seen by the neurologist for the first time. The provider carried out a medically appropriate exam, orders an MRI, initiates treatment with sumatriptan, and provides detailed counseling about avoiding triggers. No coordination with other providers took place. Okay, coders, your time begins now. Coders, I want to point out at the top, I have a top right, I have a comprehensive list that kind of guides you on what you should be documenting, what should be in your inventory. Okay? Well, we've just learned that these four elements have to be addressed. We have to answer it. Was a history and or an exam carried out? And I'm saying yes, because a medically appropriate exam took place. Also, where is the location of this visit? Well, it's an office visit because the patient is seen by the neurologist for the first time. Often that's in an office. Also, too, coders, this is not a consultation, and you will learn how to determine a consultation when you watch the introduction to E&M videos. So make sure that you do that. Also, what type of visit? I just said it's new, and it is indeed. And finally, was the MDM indicated? Was the medical decision making indicated? The answer is no. So we're going to have to score it using the PDR chart. Speaking of PDR, let's go ahead and figure out or kind of guess what the problems, data, and the risk are. So we only have one diagnosis. This is a new onset of, of a migraine. Now, coders, when it's new like that, keyword is acute. Remember that. Also, the data. What did the doctor do? Well, we know he carried out an exam, but the doctor ordered an MRI. Now, when they start prescribing medicine, as in this case, sumatriptan, this falls under risk. Remember? So, the risk is that the patient had treatment with, well, the doctor prescribed sumatriptan. Now let's go ahead and let's use the chart to get our code. Okay, my PDR is right here, and so is my inventory if we need to reference it. But of course, the documentation is here as well. So what I'm going to do is I'm going to address the problems. The problems are in the first column, and I need to determine if my problem of migraine is a minimal, a straightforward problem, a low, a moderate, or a high. Okay, high's not here, so I can just tell you ahead. I can just let you know it's not high. All right. So where does migraines fall? Is it a self-limited or minor problem? I wouldn't say that's a minor problem. Is it two or more self-limited or minor problems? No, it's one. Is it one stable chronic illness? Well, we did say it was acute, right? So new onset. So I'm not going to say it's stable. I want to use acute. So is it one acute, uncomplicated illness or injury? It could be, but I like one. I don't know if it's uncomplicated. That's the thing. The provider has to say that. So I'm torn between acute uncomplicated illness or one stable acute illness. So if I really needed help, I would go to the guidelines. You see, this is the green pages. The definitions of the problems are here. And sometimes you can get clear guidance, and sometimes you can't. And this might be that time, but let's go ahead and read. It says, an acute, uncomplicated illness or injury requiring hospital inpatient or observation level of care, a recent or new short term problem with low risk of morbidity for which treatment is required. There is little to no risk of mortality with treatment, and full recovery without functional impairment is expected. The treatment required is delivered in a hospital inpatient or observation level setting. Hmm. Well, I don't think we're in the hospital, but it doesn't mean it doesn't apply. Now, the stable acute illness is a problem that's new or recent for which treatment has been initiated. The patient is improved, and while resolution may not be complete, it is stable with respect to this condition. Okay, I don't know if the condition has improved, but I'm sticking with stable. Now, coders, if you say, hey, I disagree, Mrs. J, I think it falls under acute, uncomplicated illness, then go ahead and select it. Do you know why? Because they're both in the low category. I told you it is subjective, right? All right, so we're going to go ahead and put our low P on our scoreboard. So the problem's low, okay? All right, next we're going to evaluate the data. So we're going to just see where we fall, and it turns out that we are in the low data because the physician ordered an MRI, and that's all that he did in terms of data. So we've got a low data. Let me go ahead and put it on the scoreboard. And finally, let's go look at the risk. The risk, remember, anytime the doctor writes a prescription, then it is moderate. So let's go ahead and click on our prescription, and we're going to our scoreboard, and the risk is moderate. So your PDR is low, low, moderate. Now it's time to level because we don't know if it falls in the low category or the moderate. Whenever you have elements from different categories, then you are going to have to do this technique called leveling. And this is how you do it. All right. So essentially, you throw out the lowest level And in this case, low is the lowest level. Then you select the next lowest, and that's your code. So the next lowest of the remaining is low, and that is where you're going to code from. So our scenario wants to know, is it straightforward, low, moderate, or high? And our answer is low. And if you said low, excellent. But something, if you learned something, that is priceless. All right, coders, are you ready for the next one? I know I'm moving fast. I know I'm moving fast. I believe I have one or two more, and then Mr. Sandeep is going to take over, and he's going to slow it up just a bit. But I need to get all this information in, and I do apologize. All right. A 72-year-old female with diabetes and CKD stage 3 comes in for routine follow up. The provider carries out a medically appropriate history, reviews labs ordered by the nephrologist, and adjusts medications based on those results. The risk is moderate due to medication changes, and the data reviewed includes two external tests. Select the E&M code based upon the MDM for this visit. Okay, coders, your time has already begun. Please place your answers in the chat. Now, this time, we need the code. And the inventory that we've documented, history and or exam. Was it carried out? Yes or no? We're going to say yes because a medically appropriate history took place. Next question. Is this Where is the location of this visit? And we're going to say office visit because the patient comes in for a routine follow-up, and that's typically a visit. And routine follow-up indicates that they were just seen, and we're going to select established for the type of visit. Also, total time is not applicable, so we will need to select the MDM using the PDR chart or the E&M table, whichever you choose. Now, while we're here, let's go ahead and list the problems, the data, and the risk. Well, it says the patient has both diabetes mellitus and CKD stage 3. So this patient has two problems, and I want to note that they are two chronic conditions. And if you want to know what a chronic condition is, it's an illness that's expected to last for, I forgot, a year or so, but we know that diabetes mellitus and CKD is going to be for the life of the patient 9 times out of 10. All right? The data, essentially in the last sentence, it says that the data reviewed includes two external tests. So they give it to us right off the PDR sheet. And the risk, they also tell us too that the risk is moderate because the doctor changed the medication. So we got some gifts here. Now let's go to our chart and let's solve this code. First things first, if you look at your problems, it says that we have diabetes mellitus and CKD stage 2. So this means we have two chronic conditions. These conditions will last probably for the life of the patient. So these are indeed chronic illnesses. So let's go to the problems list. We've already covered what a low is. So I'm moving beyond low and I'm going directly to moderate. And I like this: two or more stable chronic illnesses, because these are considered stable because the doctor did not say they were unstable. If the doctor had said they were unstable, then they would be unstable. And if they're not unstable, they are stable. So that is my selection for the problems. The data. What is my selection for the data? Well, I like the review of prior external notes from each unique source. Well, in the documentation, it says that the doctor reviewed two external tests, right? So that is what I'm going to do. The doctor reviewed the external tests. So there you go. Now, risk. The risk is quite easy. Anytime they're adjusting medication or writing a script, it's going to be prescription drug management and moderate. So let's review. Our problem is moderate. Our data is low. Our risk is also moderate. So let's go ahead and put it here. We're going to score it. We are going to level. All right, coders. So how do you level it? Well, you are going to have to throw out the lowest level, which is data, and select the next level. All right, so the next level is the only, there are two of the same, so we can only say moderate, and that is our level. So now that we know our level, we need to code for an office visit for an established patient with moderate MDM. If you look up 99214, this is the code for office visit, established patient, moderate level of medical decision making. All right, so if you want to write it on the outside of the code so you can see it really quickly, established, moderate, MDM. And our inventory kind of confirms that's what we were looking for. Office visit, established, moderate, MDM. Okay, coders. If you said 99214, outstanding. Okay, that's all I have for now. And it's time for me to hand it over to Mr. Sandeep. Okay, Mr. Sandeep, they're all yours. Take it away.
Thank you, Mrs. J. And coders, here is your next scenario. Of the following answers, which best describes the encounter? Your options are option A 99385, option B 99386, option C 99387, option D 99396. A 40-year-old male visits his PCP for an annual preventive exam. He previously had an uneventful preventive visit last year and reports no current complaints. The provider performs a comprehensive history and physical, gives lifestyle counseling, and recommends age appropriate screening. Of the following answers, which best describes the encounter? And you got 1.5 minutes to solve this one. So your time begins now. And that is time. So I can see wonderful, wonderful answers in the chat. So let's go ahead and solve this scenario. Let's have a look into these preventive medicine codes. So we have code series from 99381 through 99387, which is coding for an initial comprehensive preventive medicine, or in other words, these are for a new patient comprehensive preventive medicine services. Also, we have codes from 99391 through 99397, which is for a periodic comprehensive preventive medicine, or these are for an established patient preventive medicine visits, right? Okay, next thing to keep a note is that these codes are driven by age. You can see in the code language for 99381, this is for an initial comprehensive preventive medicine for an infant, and the age is 1 year or below. And we have 99382, that's for an early childhood, age ranges from 1 through 4 years. Okay, so always remember, first Check the age of the patient. Also, check whether this is a new patient preventive medicine visit or an established patient preventive medicine visit. Also, Chorus, you have to check whether there is any abnormalities encountered during the preventive medicine visit or any pre-existing problem were addressed in the current visit. Because if a problem or an abnormality is addressed which is significant enough to require an additional workup to perform the key components of problem oriented evaluation and management service, then you have to append appropriate office or outpatient visit codes as well. And you will append a modifier 25 to the office or outpatient visit codes to indicate a significant and separately identifiable E&M service which was provided on the same day of the preventive medicine visit. Okay, now let's come back to our scenario, and here we have a 40-year-old male who visits PCP for an annual preventive exam, and he previously had an uneventful preventive visit last year and reports no current complaints. Which means from these two statements, it's clear that this is an established patient preventive medicine service or preventive medicine visit, and patient is not having any current complaint, and no current complaint was addressed in this visit as well. Okay, so with that, I can easily eliminate three options from these codes: 99385, 99386, and 99387, because all of these options are for a new patient or an initial preventive medicine visit, right? So 99385, 99386, and 99387 have to go, and the last remaining option is 99396, which is coding for a periodic comprehensive preventive medicine for a patient whose age ranges between 40 years to 64 years, right? So yes, let's cross check with our scenario. The patient's age in our scenario was also 40 years, and 99396 is the correct answer. Way to code. You all did a fantastic job. Great. And now it's time for us to move on to the next question. And of the following, which best describe the discharge day management? Options are option A 99238, option B 99239, option C 99495, option D 99496. A 58-year-old male is discharged after 4-day hospitalization for pneumonia. The physician documents a final exam, confirms discharge instructions and medication reconciliation, and spends 30 minutes on discharge day. Of the following answers, which best describes the discharge day management? And Chorus, your time begins now. So once again, great coding. Everyone did a fantastic job. So let's go ahead and solve this scenario. Now let's look into the CPT code 99495 and 99496, option C and option D. These are for a transitional care management service, right? Yes. Now coders, let me know in the chat. Are we looking for a transitional care management service codes? No, right? No. We are looking at a discharge day management service CPT code in this scenario. Yes. So transitional care management services are different from a discharge day service. So option C and option D both are incorrect. Both has to go. We're left with option A and option B, 99238 and 99239. Now these codes are for a hospital inpatient or observation discharge day management service, and they are used to report total duration of time a physician or other qualified healthcare professional spends on the date of discharge, even if the time is not continuous. Okay, so 99238 is used when discharge day services are given for 30 minutes or less on the date of encounter, while 99239 is used when more than 30 minutes on the date of encounter is spent. So let's check our scenario and let's see how many or how much time was spent on the date of discharge giving those discharge instructions, and we can see that it's 30 minutes. Yes, final exam confirms discharge instructions and medication reconciliation and spends 30 minutes on the date of discharge. So it's 30 minutes of discharge care service given, and I think 99238 is the most suitable code because 99239 should be used when we have 31 minutes or more of discharge care service. So, yes, option B is also incorrect. The correct answer is going to be option A, 99238. Okay, coders, how are you all doing? Awesome. So let's go ahead and let's look into the next scenario. Okay, coders, here is your next exercise. Of the following answers, which best describe the critical care E&M service? Option A 99291, option B 99468, option C 99477, and option D 99471. A 6-month-old infant is admitted to the PICU with respiratory failure due to RSV bronchiolitis. The pediatric intensivist rendered critical care service including interpretation of physiologic data, continuous monitoring, initiation of high flow nasal cannula oxygen, frequent suctioning, and management of IV fluids. Care was provided throughout the initial admission day. Of the following answers, which best describe the critical care E&M service? And coders, you know the drill. Your time begins now. All the best. Okay, so this is a great scenario and good answers in the chat, by the way. So let's break this down and let's do it together. Okay, critical care services has a lot of guidelines, and these are the FTRs for critical care services. Now let's look into the option 99477. It is coding for an initial hospital care per day for the evaluation and management of a neonate 28 days of age or younger who requires intensive observation, frequent intervention, and other intensive care services. So 99477 represent the initial day of inpatient care for a child who is not critically ill but still requires intensive observations. Okay, so intensive care services are just below the critical care service. Critical care service comes always first, then comes the intensive care services, right? Okay, and we are here looking for a critical care E&M service, not an intensive care service. Also, 99477 is incorrect in another way because of the age. It's coding for a neonate who is 28 days or younger, while the age of the patient in our scenario is 6 months. So it is incorrect in two ways. It's coding for a wrong service, it's coding for an intensive care service. Also, the age category doesn't fit our scenario. So option C 99477 has to go. Let's look into the next code 99291. That's option A, which is coding for critical care evaluation and management of critically ill or critically injured patient first 30 to 74 minutes. Now these are time based codes, and if you look into the FDR you can see that 99291 and 99292 is used mainly for outpatient critical care services. Okay, and in our scenario the patient was admitted to PICU, so this is an inpatient critical care service scenario and not an outpatient critical care service. Okay, so I can eliminate option A as well. We are left with option B and D. So option B is for 99468, that is for initial inpatient neonatal critical care per day for the evaluation and management of critically ill neonate 28 days of age or younger. So it's clear from the code language this is for an inpatient critical care for a neonate and not for a 6 months old infant, right? So neonate for the age 28 days or younger. And that makes option B also incorrect. And the correct answer would be option D, that is coding for 99471. That's for initial inpatient pediatric critical care per day for the evaluation and management of critically ill infant or younger child or young child 29 days through 24 months of age. And Codis, it is also important to note that reporting of pediatric and neonatal critical care service is not based on the time or the type of the unit, and it is not also dependent upon the type of the physician or other qualified healthcare professional delivering the care. Okay, so even a pediatric intensivist can provide the critical care services. Even it can be provided in a PICU as well. Okay, it's not dependent upon the unit, it's not dependent upon the type or the physician, the type of the physician as well. So the correct answer for this scenario is going to be option B, D 99471. Fantastic answers. You all are doing a great job. Okay, Curtis. So let's move on to the next one. Of the following answers, which best describe the encounter? Option A 99281, option B 99282, option C 99283, option D 99284. A 29-year-old male is seen in the ED for dislocated shoulder following a sport injury. The provider performs a problem focused history and exam, orders an X ray, and performs shoulder reduction under sedation. Of the following answers, which best describe the encounter? And coders, your time begins now. Now, before we start solving the scenario, let's ask some of these questions. What was the location of the visit in this scenario? You can type your answers in the chat. Yes, it was an emergency department, right? True. How about the type of the visit? Is it a new patient or an established patient? Well, it's not applicable because it is not going to drive our answer or the code selection, because in emergency department there's nothing like a new patient or an established patient. Okay, so these codes are not driven by whether it's a new patient or an established patient. Now, was there a total time documented for this visit? No, right? No, there is no total time documented. And was there any history or exam, medically appropriate history or exam, or medical decision making performed? Yes, it was performed. So, shall we use an E&M table to select the code? Yes. So, let's solve this scenario. Now, this is the PDR chart with the help of which we are going to select the correct E&M level. Okay, to use this PDR chart, we would need to know number of problem at rest, the data reviewed, and the risk of complication. So that's your P, T, and R. Okay, so let's first look the problem at rest or number of problem at rest. So here in this scenario, we have only one problem at rest, and that would be a dislocation of the shoulder, right? Patient had a dislocated shoulder and treatment was given for a dislocated shoulder. So we have only one problem, and that would be one acute uncomplicated injury, right? It will fall under acute uncomplicated illness or injury, and that would be a low problem. Okay, coders, are we good? Excellent. Now let's move our attention to the data. So, how many or what data was reviewed in this scenario? We had an order of an X-ray, right? So I would say we have a minimal data. Yes, because only one X-ray was ordered, and that is only 1 point. So for it to be a low or a limited data, you must satisfy either category 1 or category 2. Okay, the category 2 is assessment requiring independent historian. So there was no assessment requiring independent historian performed. And for category 1, you need any combination of the following: the review of prior external notes from each unique source, review of results of each unique test, ordering of each unique test. And we didn't had a combination of two. We had only 1 point from this, and that is an order of an X-ray. So it doesn't satisfy low category of data reviewed. Okay, so we have only a minimal data reviewed. Okay, now let's move on to the risk. And what was done here? We had a shoulder reduction performed, and that was under a sedation. Okay, right? That was under sedation. So that qualifies for a moderate level of risk. Okay, yes, a decision regarding minor surgery with identified patient or procedure risk factor. So this was done under a sedation, and that qualifies for a moderate level of risk. And now it's time to pick our final E&M level. So since it is not a match, the problem, data and risk is not a match. So what we are going to do, we are going to throw the lowest level out and select the next highest level. And that would be a low level of E&M. Okay, low level MDM. So for a low level MDM, the correct answer is going to be 99283. Emergency department visit for the evaluation and management of patient which require a medically appropriate history, an exam, and a low level of medical decision making. Okay, so is it clear, coders? Fantastic. Okay, let's move on and let's do another scenario. Of the following answers, which best describe the encounter? Option A 99202, option B 99212, option C 99203, option D 99213. A 23-year-old female with burning upon urination is seen by Dr. Samuel, who was covering for her PCP. The provider takes a brief history, examines the abdomen, orders a urine culture. The patient is diagnosed with urinary tract infection and prescribed antibiotics. No labs or additional services are ordered. Of the following answers, which best describe the encounter? Okay, coders, see you after 1.5 minutes. All the best. And that's time, coders. How are you all doing? Okay, okay, you all have done a great job for this scenario. I can see your answers in the chat. Great. Okay, coders, now let's start by answering these questions. What was the location of the visit? Yes, you are correct. It is an office visit encounter. How about the type of the visit? Is it a new patient or an established patient? Okay, okay, great. Okay, so in situation where a physician or other qualified healthcare professional is on call or covering for another provider, the patient's encounter should be classified as it would have been if the regular physician or healthcare professional had been available. So in this scenario, you can see Dr. Samuel was covering for her PCP, right? Was covering for the patient's PCP visit. So, yes, this is going to be an established patient visit. Okay, great. Now let's look into the next question. Was there any time documentation? I don't see any time documented for the scenario. So also there was a medically appropriate history and exam performed and medical decision making was also done. And next we are going to use our E&M table to select the correct E&M code. And let's do that. Once again, we are going to take the help of our PDR chart to solve the scenario or to select the correct E&M level or E&M code. Okay, so let's inventory the PDR chart. What problem was addressed or how many problem was addressed in the scenario? Correct. We had only one problem that was addressed and that was treated, and that would be a urinary tract infection. A patient was diagnosed with a urinary tract infection, and again, it falls under acute uncomplicated illness, and that would be a low problem. How are you all doing, coders? Yes. So we have a low problem. Now let's look into the data. And in data, we have an order for urine culture. And that was the only order in this scenario. So it would qualify only for a minimal data. It doesn't qualify for a low data. So we have a low problem and minimal data. Now it's time for risk of complication, and here doctor prescribed an antibiotic prescriptions or antibiotic medicines. So in the risk column, it falls under a moderate risk, and you can see an example given under moderate risk. Prescription drug management, yes, so antibiotic prescription management was performed in the scenario and it qualifies for a moderate risk. So we have a low problem, minimal data, and moderate risk. So once again, this is not a match. So we have to throw the lowest level out and then select the next highest level. So we throw the straightforward or minimal level and select the next one. That would be a low level MDM. So let's look into our CPT manual and select the code for a low level established patient E&M outpatient code. That would be 99213, which is for evaluation management established patient which require medically appropriate history and or examination low level medical decision making. You all are doing an amazing job with this PDR chart. Great, awesome. So it's time for me to hand over to Mrs. J, who's going to come up with a great instructions. Okay, thank you, Mrs. J. Back to you.
Thank you, Mr. Sandeep, for that stellar instruction. You know, he's our CPT expert, and for good reason. Thanks again, Mr. Sandeep. Now, let's switch gears. I want to take this opportunity to show you the evaluation and management tool. In fact, we are going to recommend that you purchase the AAPC exam prep bundles, those exams A, B, and C, or D, E, F, because you will get an evaluation and management tool to take your exam. Yes, you will be using or able to use a tool, or you can code it by hand. It will be up to you. But let me demonstrate how an evaluation and management tool works. Now, if you're taking the CCS-P, nope, you won't have a tool to use, but you should be okay. Just saying. All right, so here is the Find a Code tool. It's very similar to the AAPC tool. So I'm going to log in to my Find a Code account. Then I'm going to click on Tools. After I click on Tools, I'm going to click on Calendar or Calendars, then the E and M calculator. After I click on that calculator, I land here. Then I will need to select my calculator. So I'm going to calculate. I'm going to need a calculator, a current calculator. I'm going to click on here. Then I will need to select what type of encounter it is. Is it office new, office established, hospital, inpatient, observation, subsequent hospital, observation, hospital admission and discharge on the same day, discharge services, other, etc. So there's going to be a list that you'll need to choose from. So let's say that we're a new patient, right? And we click on that. Whatever we click on, it's going to have a drop down menu like you see here. It's going to ask you, do you want to calculate it based on MDM or time? If the time is not present, then you're going to select MDM. And that's only for the exam, right? Only for the exam. But in the real world, anytime you can do MDM, do it. All right? Now, we've clicked MDM. It's going to go right into it. It's going to ask you, was a medically appropriate history documented? If so, check it. If not, don't check it. Was a medically appropriate exam carried out? Check it off. Then you will encounter a chart that looks very much like our PDR, and this is the problems chart. They want to know the number and complexity of problems addressed. Just like the PDR chart, you make your selection. Then your result will be here. So if you make a selection in the low section, your result will be low. Also, the data. The data chart is very similar to our PDRs as well. And the difference, and I like this, is you have three columns next to any element requiring each unique source, test, etc. So for the review of prior external notes. If you have more than one note that the doctor viewed, you'll check off the first note, the second note, and the third. The same with reviewing each unique test, first, second, third, and ordering those tests. Each unique has its own um, checkbox. Now, if it exceeds three, then I think you're good. I think you'll be okay. Just check off the maximum. And finally, here is your risk table, very much like our PDR. All right, so if it's minimal, low, moderate, or high, check it off. And when you're finished with all three, it's going to level it for you. Now, let's go ahead and let's demonstrate this tool. All right. A 42-year-old female presents to the office for a new patient visit, complaining of persistent headaches and fatigue for the past 3 weeks. The physician takes a detailed history, performs a comprehensive examination, and reviews the patient's prior medical records. The physician orders a complete blood count and a basic metabolic panel. Based on the findings, the physician diagnoses the patient with tension headaches and discusses lifestyle modifications, stress management techniques, and over the counter pain relief options. The physician also schedules a follow up visit in 4 weeks to monitor the patient's progress. Of the following answers, select the correct CPT code for this procedure. Okay, coders, the time has already begun. I tried to read slowly, and coders, I want you to know you should go ahead and solve this scenario manually, and we're going to check our answer by using the tool. All right, your time has already begun. And you can do this, coders. All right. So, how did you do, coders? Did you come up with the answer? Well, I'm going to speak a little more slowly, and that way you can come up with the answer. Give you a little more time. Okay. So, the first thing that we are going to do is inventory, right? Let's go ahead and inventory. The location office visit, new or established, it's new. The total time is not applicable. And yes, we will need to use those E&M tables, you will, or the tool to select the answer. Okay. And the PDR that I have for problems, I put tension headaches. And I think it's acute. It's acute because it's happening now. Patient's been having these persistent headaches for 3 weeks, right? And the doctor diagnoses the patient with tension headaches after he looked at the records and the blood, etc. So that's going into the data. And the data is that he reviewed the medical records and he ordered a CPC and a basic metabolic panel. Now the risk of the treatment, well, I'm not sure what it is, but I'm going to write down the treatment. He counseled and stressed and administered stress management techniques. Also ordered the patient to have over the counter medicine. So, you know what? Let me take out ordered. The doctor told the patient to buy some medication over the counter. And I just want to let you know that that is not prescription drug management. Now, let's go ahead and let's use the tool and let's see if you come up with the same answer that the tool does. After we select the current year calculator, we're going to come to the list of visits, right? Now, in our inventory, we've listed office visit new as our visit. So we're going to click on the one at the top, the very first one. And then we're going to land here. And it's going to ask us, do you want to calculate this based on MDM or time? And there's no time documented in our documentation. And we said total time is not applicable. So we're going to calculate this based on the MDM. We're going to click it. And we're going to land here. And we're going to see the problem table. So it's time for us to determine the number and the complexity of problems assessed. As you can see, I selected one acute uncomplicated injury or illness. And that is, I believe that's what it is. This patient had a tension headache, and it is acute for the reasons that I've specified before. So this is my selection. So coders, do you have any other selections? Go ahead, type it in the chat. So do you think something else is applicable? Do you think it's a stable acute illness? That could be correct because actually we don't really have enough information. So you can go ahead and make that determination and you would not be incorrect. But nonetheless, we've got this, we're going to have the same outcome. It's going to be a low level. Now, if you're going down into moderate coders, please type in the chat and let me know. So after I made my selection, my result will appear here, low. Now I'm on to the data. Oh, also too, go ahead and let's go ahead and put our P at the bottom. We have a low P. Now let's turn our attention to the data. And if you see the data on our PDR, it says that this provider reviewed the medical records and ordered a CBC and a BMP. So I like to always keep the documentation because I'm not perfect. I could miss something. I do a lot of things at one time. So if I've missed anything, please type in the chat. All right, so it says reviewed the medical records, so that's one unique source. Review of prior external notes from each unique source. Or you could say review of results from each unique test. Maybe not. I don't think so. I like this for reviewing of medical records. Also, the two tests ordered. Under ordering of each unique test, the CPC and the BMP. So that's what we've listed, and the tool says, hey, you've got a moderate result. You've got moderate data. Why do you have moderate data? Because you have to have a combination of two of the three in category one, and we've got three. We've got one, two, three. All right, so our data is moderate. And we're going to go ahead and document that moderate data. And finally, the risk. And I believe the risk to be low risk. And the reason is the doctor provided counseling, stress management techniques, and said, hey, you need to purchase some medications over the counter. The doctor did not provide any prescription drug, but the doctor did do some things. I'm not going to classify it as minimal because um, you never know. I think it's low. That's my coding judgment, not clinical, my coding judgment that it's low because the doctor did provide some counseling and there is a low risk from that treatment. This is just my coding judgment. Now, somebody might say, well, I think it should be minimum. So, okay, go ahead and put minimum. And somebody said, I think it's moderate. I believe that would be wrong because they're talking about minor surgery, elective surgery, etc. And that didn't take place. Neither did the prescription drug. So if you said minimal or you said low, then that would be correct. So I'm saying low and my risk is low. And if you said minimal, we're going to have the same result. Just saying, coders. All right, so it's time to level. Let's see how the tool leveled. All right, so here is the result. We had a limited number of problems. We had a moderate data, and we had a low risk. So the MDM is low. And I do want to point out that limited is the same as low. Okay. So that is one little fluke that they put in there. So it is low and limited is low as you can see on your chart. Now let's go ahead, coders, and let's level, right? Yeah. So you throw out the lowest, you throw out the low, you code the next lowest, and your answer is low, right? And if you said low, outstanding. All right, coders, so this concludes our instruction. And if you want to practice more leveling, and also if you want to talk about these locations or these visits in more detail, you are invited to join me on my Wednesday Discord at 12 o'clock p.m. And we are talking one on one. So you are welcome to come. Of course, you have to be a silver, gold, or platinum member. All right, so let's go ahead and let's end this session appropriately. We reviewed in week 16 evaluation and management. We did practice exercises to test your knowledge. I think I dropped one gem. And hopefully, we brought you one step closer to CPT coding mastery. Now let's review the homework. All right, you can find the homework on the syllabus at www.amcicoding. Click on YouTube course. And anyone, if you know anyone that wants to take this 16-week course, tell them to go to the webpage and click on YouTube course. And they'll need to locate the syllabus and download it. After download, they can see all of the required textbooks for this course. Now, here is the homework for week 16. And it's not a lot, no. It's not a lot in numbers, but it is a lot in depth. All right. So if you, number one, are in Discord, go ahead and download this class playback handout. Number two, if you need to watch this playback, go ahead and do so. Click that green highlighted hyperlink. Number three, mandatory coders. I hope you have the MCG. Please, you need to watch these four lectures. All right, so you click on that link for additional resources from your MCG manual, and you have these four parts one, two, three, and four. I break it down Barney style right there. If you need it like that, go ahead. Also, too, those conversations that we didn't have, if you feel like tonight or today, whenever you're watching, that you didn't get something, it's probably right there. We talk about guidelines more. We talk about those location, those visits more. So please do yourself a favor and watch them. Also, your reading assignment from Bucks, Unit 3, Chapter 11 on evaluation and management. 5. Watch how to code E&M. Now, coders, I will tell you this. If you don't have the MCG manual, don't feel like, oh, Mrs. J is pressuring us. No, that's for the people that have it. If you have the MCG, definitely watch the one, two, three, four. Now, if you don't have it, and if you do have it, you still should watch these parts one, two, three, and four. Those conversations are also bridged. They're a little more advanced, but they are here too, not the exact same, but this is good as well. So definitely watch these four parts of evaluation and management coding. Number 6, as always, go chun the evaluation and management section, and you'll need to join the chun group on Facebook. After you join it, click media, then album, then boom, find evaluation and management. As you can see, it's number 1. Okay, coders, after you've chunned, you are ready to take your MCG quiz. If you have it, take your quiz. And yes, you have to access it through the MCG. There it is. And you've got a final exam, and it will be ready after 7/7. You have 2 final exams. The first one is ready now. You can go ahead and take it, right? And you need your MCG. So go ahead, click on your MCG, take your final exam. Now the second one is the one that counts. That second one is where you'll get your certificate of completion, the one with the YouTube. So consider the first one a practice. We want you to have practice. And that second one with the YouTube, this is where you'll get the certificate of completion, and it will be available after 7/7 because I don't want you to rush it. We call ourselves guiding you through the course, and we don't want to push you to do anything. All right, coders. So that is your final homework. Now, also, don't forget, we do have optional podcasts that are, available if you don't have the ability to sit and watch, or you just want to listen. These are guideline driven, so we encourage you to listen to the podcast. And the link is on your syllabus. Don't forget our Discord programming. We have IMTAP every Wednesday at 7 p.m., AMCI Game Night Fridays at 7 p.m., and My Luncheon every Wednesday from 12 to 1 p.m. Coders, this is your time to talk directly to me and the AMCI instructors. Also, we've got these courses for you, a full CCS-P course, a full CPC course, and a full CCS course. Remember, these are everything is a la carte or boutique style. You can just pick and choose what you like. However, at the top, if you want a full course, we tell you how to do it. And it's low cost, no contracts. You just pay as you go. And don't forget, next week I will be recording or uploading the recording of the recommendations to pass the CCSP, CPC, and CCS exams for free. All right? So it will be uploaded. And to everyone that's completed a survey, I want to just say thank you. Week after week after week, the same people fill out the survey. If you've never done it, please complete this survey. It helps us help others. And it also helps us deliver more content. We want to know what you like, what you need, and this is the way you can speak to us directly. And yes, we will be implementing a lot of your suggestions. And if you don't think that boutique course didn't come from surveys, think again, coders. Think again. It is a gift, it is very low cost, and it is valued. It's highly, highly undervalued, but we did it for you. Okay, now we need you to like us up or thumbs down. Let us know how we did for week 16. To my extraordinary AMCI team, from the depths of my heart, I thank you. Team, you showed up every week for 16 weeks, giving your time, your talent, your tenacity, and your brilliance. Yes, yes, they gave their brilliance to this mission. And what we've completed, team, with this YouTube course was not ordinary. It was revolutionary. And that is because of you. There is no possible way I could have done this without you. You are indeed the best team. To my instructors, the administrators, to the interns, you have my endless gratitude, and I thank you. And to you, coders, I thank you as well. Becoming a world class coder isn't about knowing every code, it's about mastering the guidelines, trusting the process, and showing up even when it's hard. Yes, and you all have done that. Remember, growth lives on the other side of consistency. So thank you. Go study, go practice, and go be great. You can and you will.
4,000 exam passers and free classes at AMCI. Learn to code straight from home or on the road at AMCI. We're on the East Coast, the West Coast. We're all